If you want to know how to consistently place invisible, long-lasting cervical restorations, you're in the right place. Dr. Bud Mopper, a fellow of the American Academy of Cosmetic Dentistry, is going to show us exactly how to do that, and we're starting right now.
And now, Amazon #1 best-selling author, Dr. Tom, the Gems Guy, Orent.
Greetings from Planet Gems. I'm Dr. Tom Orent, aka the Gems Guy. If this is your first time here on the planet, welcome to the Dental Goldmine. If you're a subscriber, welcome back. As part of our ongoing series, Gems of Dental Clinical Mastery, I have the honor of presenting my friend and mentor, Dr. Bud Mopper. He's a member of the Academy of Aesthetic Dentistry, a fellow of the AACD, and he teaches postdoctoral continuing education, direct resin bonding at many major universities. Dr. Mopper received the Lifetime Achievement Award from the World Aesthetic Congress in England. He's the Director of Education at the Center for Aesthetic Excellence in Chicago and is co-founder and chairman of Cosmedent. He's my friend and mentor. Buddy, thank you so much for being with us here today.
How are you, Tom?
I'm doing great. It is absolutely amazing to have you with us. I am so looking forward to what you have to share on cervical restoration. So without any further ado, I'm going to let you take it away.
The cervical restoration is probably the most common restoration today because of the fact of you see it all the time. You see it with wear, you see it with attrition, you see it with toothbrushing abrasion, and you see it with tension. And people are probably clenching their teeth more than ever and bruxing more than ever. So let's take a look at it. You take a look at these, what you see today on the left and on the right. These are cervical restorations that were in Technicolor, terrible margins and things of that nature. And now when I want to do it, if I'm going to do it with composite, I'm going to do it so that they're invisible. Basically, that's what we look for in composite restorations, especially aesthetically, is I want to see it disappear in the tooth structure and become part of that tooth where you can't even tell whether it's a tooth structure composite. So let's take a look at this lady that comes to our practice. You can see the lesions on the first molar, 3 molars, on the lower, and you also take a look at the tissue, because I'm going to talk about the fact that if the tissue is in good shape, I will never use retraction cord. I use a method called retracting the tissue with instruments. I work with magnification so I can see, and if you can't see it, you can't do it. That's the real big thing. And this is what I go through in my presentation every single time. You need optics in order to see what you're doing. And if you take a look at these lesions, they're minimally invasive lesions. That's what I'm all about, is preservation of tooth structure, which I told you before. And we're going to preserve this tooth structure and make minimal preparation, because minimally invasive dentistry is the best type of dentistry that anybody can do. And so if you take a look at that, you can see what we're doing. And what are we replacing primarily in these restorations? These restorations are enamel lesions, okay, basically. They're in the enamel, you're replacing enamel. When I'm replacing enamel, the restorative material that I'm going to use is microfil. Most of you are not using microfil. You should be, because that's the only one that truly replicates the enamel surface as closely as possible in every fashion, both in polishability, in durability, in the ability to marginate, in tissue compatibility, and in every single fashion, okay? So that's the material we're going to use. But let's go through the procedure. In this slide, you see the use of a micro burr. I love the micro burrs. I developed a kit from Brasser, and in it, the kit is a micro burr. This is a pear-shaped burr. And why do I like smaller burrs? Because it gives me access, great access to very tight areas. And I'm running this under copious amounts of water at about 10,000 RPM. Yeah, and that gives me control. I use an electric handpiece. That gives me more ultimate control. But I'm just going to roughen up the sclerotic zone. I don't use prophylaxis paste or prophy down there because it will irritate the gingival. With these burrs, I've got complete control, and I can define that margin anywhere I want it. Then we'll transfer to a mini flame-shaped burr to define the gingival margin, where it's going to go, about 2 to 3 tests beneath the free margin. I'm never going to end at the gingival crest because that's not the aesthetic zone, and I'm not going to end above the gingival crest. I'm taking it slightly beneath the free margin, then you'll never see it. And the way we marginate is so compatible with tissues that you'll very seldom do you see resection. So you can see we're prepping that margin. Okay, then towards the sizable, I'll use a 68, 62 diamond and bevel, make a long bevel towards the clusal. Now you see we've got both of them prepped, and you can see the extent of the bevel. And I'm going to place the material, and I'm going to end past the margin of the long bevel, and I'm never coming back to that margin. I'm going to feather edge it on the two surface. So now we acid etch. You can separate any you want. You want to use Teflon tape. I use metal strips because you get into the interproximal. I find marler is very difficult going back in the posterior because it's usually too thick. So I use ultra thin metal strips. Acid etch. You can see how you can see where the enamel is. You see where the dent is. Then we place our enamel primer. Thin it, air thin it, polymerize it. And now this is sort of a Mopperism. You can do this or not. You can take the paste completely and start to sculpt it, just the microfill paste. Or I like, it's easier, it's very difficult down in that area to get the restorative material to stick in that area. So I find if I use a little bit of flowable microfill, the color of choice, and just underfill it and still keep the concavity, and it could go down to the margin, seal the margin. And it's a very thin tip, and you express it, you've got complete control. You can underfill it, polymerize that, and that's the way it looks. And there's still a concavity. What's going on there? The paste microfill. And on goes the paste microfill. Here I make a convenience form, which we talk about all the time, and I use my fingertips to roll it there. As long as you got a clean glove finger and no aerosols on it of any kind, making sure you keep that finger clean and dry, you're not going to contaminate that material. I did it with I've been doing this ever since I've been doing composite. Manipulating them with my hands before I even were using gloves. I use titanium coated instruments. This is a broader bladed instrument, rounded instrument. This is a placement instrument. And we'll sculpt it, shape it to C8A. Now we transfer, when we start to contour this and get into the more finite areas, bringing it into proximal, I'll transfer to the IPC instruments, which are real thin bladed instruments. And believe me, instrumentation is important. If you don't have the right instrumentation, you're not going to be able to do this the right way. And I will tell you right now, the most important aspect of doing the whole thing is creating the morphology. And the way to do that is through your instrumentation and proper sculpting. I am not a brusher, I'm a sculptor. And I'm going to sculpt that the way it needs to, and I'm going to get the correct morphology and maybe be slightly overbooked from the facial, but never on the proximal. And that makes polishing so much easier if you're right to contour. So now you can see I've got it in place. I polymerized the first layer. Now I'm not a genius, okay? I can't close that in one layer, that gingival margin. I never could. So people say, when you put it on the book, what about shrinkage? I never worried about shrinkage, because anything that was at the cervical margin, I always took a soft piece of material and made it into an ellipse, and then sculpted it into the gingival crevice and against the pre-polymerized material to make sure I closed down that gingival margin. And you can see the placement and how we're going to contour it and shape it and get it where we want it, and that's the way it should look. Now, besides the polishing, you've got the proper form, the proper placement of the gingival. You take a look at the tissue is unblemished. I don't have a retraction cord on there. You don't see any welling up of interclavicular fluid, and even if it did, I just blow it away and keep on going. Only if there was seepage and bleeding when I might have to back up and pack retraction cord. So now you can work in quadrants, because these are not approximating one another in the contact areas. So I do three. I don't want to polish one and then go to the next one and have bleeding and things of that nature. So I can work in quadrant form. So I've got the three done as far as placement is concerned, the shaping, the finishing, and this is all microfill. Why? Because microfill has flex much better than the other two materials, nanofill or microhybrid. Microhybrid failed. Even with the flowables, it stayed. It fell off. It was terrible. And I knew it wouldn't work, and I kept saying it wouldn't work. Microfill is the king down here at the cervical area, if you can do that. If it's really deep, then we have to talk about something else. But in these type of lesions, they're all microfill. So we're going to finish and polish now. And I usually start with either a coarse disc or an ET burr. In this particular instance, I'm using the ET burr, the 12 fluid, to contour. And I'll use my wrist in any direction. Now you see I'm cutting on the first slide, I'm cutting more towards the top and laying the burr back towards the occlusal edge, okay? Now, when I go down towards the gingival, you see that the blade is tipped away from the tooth, and I'm cutting down at the cervical. That's the way to make a straight blade form a curved surface. If you don't move your wrist in order to accomplish that, then you're going to have a flat appearance, and you're going to end up with over-contouring the restoration. So you have to follow the contour of the tooth surface. Then we'll finitely move that, blend that occlusal margin in the tooth surface using the coarse disc with pressure at probably about 10,000 RPMs, and you're going to refine it, and you'll see that white line and raised line disappear in the tooth surface. And when that does, then you go to medium, the fine, and superfine. Until that line disappears with the coarse disc, you can't go to the rest of the finishing process. The coarse disc is what's going to do it for you. So you take the coarse disc, get that line to disappear, then you go to fine, or to medium, fine, and superfine. And then the final key to the whole thing is our polishing paste, which is enamellized. There's nothing like it. But I implore you, just put a little dab of dewy on each tooth. Don't smear it all over the place, and don't put it on the FlexiBuff, which is the chamois that we used to do this with. It's a mylar back disc with like a felt surface. It's like chamois your shoes. Okay, you put that on and run it at about 15,000 RPMs, and it'll amaze you at the polish that you get. And just a little dab of dewy on each tooth. So we go from here, we go to there, and that's the way it looks at a year. So what am I looking for? The disappearance of the restorative material on the tooth surface, the compatibility of the gingival tissue. You can't get a better compatibility than you see there, and it's going to last. And the thing that bothers me, and I read these peer-reviewed journals that say composite only, and they're supposedly evidence-based. I don't know whose evidence they're using. It's certainly not the evidence in my practice. Because if you did a longitudinal study on my practice, you would see how long-lasting this stuff is. And this is a one-year post-op. We'll show you a lot of long-term post-ops later on. But as you see, you take the health of this, and it's going to be compatible for many years.
Can I make a quick comment?
Yeah.
I believe that based on how you're able to do those so beautifully, especially right at the gingival margin, I think you're making the periodontist life a lot easier and making them look good.
Well, look, I've always said, okay, that you can't have, I believe in soft tissue management, and I can show that later on in some things that we do, because the pink is just as important as the white, okay? But in order to preserve the pink, you've got to do the technique. When I hear all these things about it doesn't last, and it's horrible to the gingival tissue. That's because they haven't done the technique right, and they haven't used the proper materials, and nobody knows it better than I do. Because I've done more of these than probably any 10 dentists in the world, and that's no lie, okay, over my 50 years. And I know how compatible it is with the gingival tissue. So I can help the periodontists in so many ways, and they can help me. And that's what the whole thing is all about, is collaboration in doing what's best for the patient. Dentists don't think they can charge for what they do. It bothers me tremendously. We don't base it on skill anymore. They don't mind charging for what the lab does, but they look at their own work, they don't think it's worth it. As far as I'm concerned, what I do is worth more than anything any laboratory can produce. I'm not knocking labs. We need labs all the time. But you've got to place a skill level on your skill. And if you're going to do something like that, then you've got to charge commensurate to it, or you won't do it. And that's the truth, okay? So now let me go back into these. These are restorations or lesions under a kid after he had the braces off. The patient just spent a ton on braces, and you see what you see. Now, when we go ahead and prep it, I've got bevels up there, and these are deep, okay? When you're deep in those areas, then you got to bring the undercolor up to the level of the surface color, okay? And most of you maybe don't even know our system, but our system it's not based on dentin color, it's based on surface color. So if I'm going to bring that level up, and I can't do it with a microfilm because it's too translucent. I have to have something in there that's more opaque. And I'll either use the microhybrid or the nanofill. And I'll put it in that area and blend it up to the leading edge of the long bevel. And that, if it doesn't block out enough, then I'll follow it with an opaquer. And the opaquer is the same color. So if this tooth is an A1, follow me, okay? It'll be A1, either nano or microhybrid. It'll be one A1 opaquer, okay? And it'll be A1 microfill. The colors of the materials are exactly the same. Only the opacities vary. That's the uniqueness of the system, okay? So I hope you follow that out there. If you don't, go onto my virtual courses in Cosmet. It'll teach you the whole thing, okay? So here we go, all right? Now, I'll show you what to look. So that first layer, and I can't show it because I didn't do it step by step on this, but that first layer will be the nano up to the leading edge, okay? Then over the top of it, if I don't need opaquer, goes the microfill. And that's what we did. We didn't even have to use the opaquer. But let's take a look at the way we finished. This is the way we finished. You can't even tell it's been done. And that's the whole key to doing an invisible restoration. We're not patchwork dentistry. We're better than that. And now they're coming out with both those. We're dumbing down dentistry. We shouldn't be dumbing down dentistry. We're a sophisticated profession. We should be making it better and better. And in order to do that, you should charge for it. Don't diminish your own value. That's the way I feel.
Those restorations are amazing, buddy.
Thank you. I'm getting it off my chest. Let me tell you, this is what I believe.
I appreciate that you did that, because you and I are two peas in a pod. I was always an advocate of gain the skill, gain the knowledge, and the experience, and then charge what is a fair fee to both you and to the patient.
Yes. And we've gotten to the point where you have to destruct in order to construct. I don't care whether it's porcelain, where they way over prep, okay, for most of the stuff, or whether it's implants. And every dentist should be able to do what I do. And it's simple. It's not hard.
Buddy, that was nothing short of amazing. I appreciate, not only what you're showing us today, but what you've been showing us over the years. I know it made an enormous difference in my practice, and for future generations who are just getting started, that was wonderful. Thank you so much.
My pleasure. I enjoy doing this.
Yeah, just amazing work. Thank you, and be well, and to your family as well. Take care.
You too. Take care.
Thanks, buddy.